Welcome to the Deep Dive. Today, we're taking a close look at non-invasive vascular labs. The places you might go for an ultrasound to check blood flow.
hmm
And our focus, it's quality assurance and accreditation. Now, it might sound a bit dry,
A
maybe,
little bit technical, yeah.
but these ideas, they're actually borrowed from manufacturing, believe it or not. And now they're super important in healthcare to make sure that you, our listener, are getting really high-quality diagnostic tests.
Right. And for this, we're leaning on Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. We're digging into the chapters on QA, accreditation, and also something called quantitative imaging biomarkers.
EOBs, yeah.
Basically, we want to cut through the jargon, understand how healthcare tries to achieve accuracy and, real value in vascular testing.
Exactly. So today's mission, understand the methods, why accreditation matters. It's not just a certificate, right?
Definitely not.
We want to give you some insight into how healthcare really pushes for accuracy and value in these vital tests. Okay, so let's kick things off. Why is this focus on quality in healthcare so critical right now?
Well, a big driver is honestly the cost versus outcome situation in the U.S. We spend a huge amount on healthcare compared to other developed nations.
Yeah, you hear that a lot.
But our health outcomes don't always stack up. So there's this massive push for value. Think of it like a simple equation, quality divided by resource use.
Okay.
And the goal, obviously, is crank up the quality, but be smarter about the resources. Reduce that denominator.
And that quality piece, it's stark when you think about medical errors.
Yeah.
Diagnostic errors especially. I mean, the numbers are pretty shocking.
They really are. They've been cited as like the third leading cause of death in the U.S.
Wow.
Which just highlights how absolutely crucial accurate diagnosis is, getting that test right the first time.
Absolutely. So how do we even define quality in healthcare? It feels broad.
It is. But the Institute of Medicine now, the National Academy of Medicine, gave us a helpful framework. 6 domains:
Okay, what are they?
safety, effectiveness, efficiency, timeliness, patient-centeredness, and equitable care, making sure everyone gets fair access.
That gives us a really solid checklist almost for evaluating a vascular lab, doesn't it?
It does. It provides clear targets.
And it's not just about doing the right thing clinically. There are financial pressures too, aren't there? Like MAC-ERA.
Oh, definitely. The Medicare Access and Chip Reauthorization Act of 2015, MAP-ERA, that was a big shift. Trying to move away from just paying for volume, like how many tests you do.
Right, fee for service.
Exactly. Towards paying for value, using programs like MIPS and APMs. So the idea is to actually reward labs financially that show better patient outcomes and are more cost-effective.
So better quality can actually mean better reimbursement.
That's the goal, yeah. Now, what's really interesting is where healthcare got some of these quality improvement ideas from.
Right, you mentioned manufacturing earlier.
Yeah, they've been focused on systematic quality improvement for, well, a lot longer than healthcare, generally speaking.
Like the Toyota production system, TPS, I've heard of that. Designed way back, wasn't it? To cut waste, make things faster.
Exactly. And it's built on 2 main pillars, 2 key ideas.
Okay, what are those?
The first is Jidoka. It translates roughly to automation with a human touch.
Interesting phrase.
In the factory, it meant if a machine found a defect, it would stop automatically. And crucially, the worker on the line was empowered to stop the line and fix the problem.
So empowering the frontline staff.
Precisely. And the takeaway for a vascular lab from Jidoka is empowering every single technologist, every staff member to flag a potential quality issue immediately, like pulling that cord on the assembly line.
I see. And the second pillar.
That was just in time, making only what's needed when it's needed, minimizes inventory, waste, hugely influential in supply chains.
Okay, but it feels like Jidoka, that empowerment piece, has maybe a more direct link to building that quality culture in a healthcare setting.
I think that's fair to say. The just-in-time principles are maybe more about operational efficiency, while Jidoka is really about embedding quality responsibility everywhere.
Makes sense. And
Yeah.
building on that, there's Kaizen, right?
Yeah, Kaizen, the Japanese philosophy of continuous improvement, always looking for small ways to make things better every day by everyone. It's really the heart of lean management.
Okay, and then there's another big one, Six Sigma. That sounds more statistical.
It is. Six Sigma is very focused on process outputs, driving down defects, reducing variation. They use this structured method called DMAI.
DMAIC, okay. Acronym alert. What's that stand for?
Define the problem, measure its current state, analyze the root causes, improve the process, and then control it to make sure the gains stick.
Define, measure, analyze, improve, control. Got it. So it's a very data-driven, step-by-step approach.
Very much so. Aiming for near-perfect results, statistically speaking.
And sometimes you hear Lean Six Sigma, LSS, just combining the two.
Yep. LSS blends Lean's focus on waste reduction and flow with Six Sigma's focus on defect reduction. Lots of hospitals and labs have tried implementing LSS.
And how's that gone? A silver bullet?
Mixed results, honestly. Healthcare is complex. Applying these manufacturing models isn't always a straightforward plug and play. Sometimes the culture is different too.
How so?
Well, TPS really emphasizes that bottom-up improvement, like we said with Kaizen. Everyone contributes. Some traditional management structures are more top-down when it comes to quality initiatives.
Right. Okay, so let's bring this down to the lab level. We hear terms like quality control, QC, on quality assurance, QA. How do they fit together?
Okay, good question. Think of quality control, QC, as being focused on fulfilling specific quality requirements for the product.
And in this case, the product is the diagnostic study, the ultrasound images and report.
Exactly. So QC is about the specific checks and tests to make sure that study meets the necessary standards. Is the image clear? Are the measurements right?
Got it. Checking the actual output.
Right. Then quality assurance, QA, is the bigger picture. It's the overall system that provides confidence both internally and externally that those quality requirements will be met consistently.
So QA is the framework, the processes, the policies.
Precisely. It assures everyone, the lab staff, doctors, patients, accreditors, that the lab has reliable processes in place to produce quality results.
And within these, you mentioned inspection and auditing.
Yeah. Inspection is really part of QC. It's the hands-on measuring, examining, testing of the product, the study against the standards.
Like looking at the images themselves.
Exactly. Auditing, on the other hand, is more of a QA function. It's about evaluating the processes and controls. Are they being followed? Are they effective? An audit might use inspection techniques, but its main goal isn't to accept or reject one specific study. It's to check the system.
Okay, so QC inspection, checking the what?
Yeah.
Q auditing, checking the how and why.
That's a good way to put it.
Now, what about TQM and CQI? Total quality management and continuous quality improvement.
Right. TQM and CQI are broader organizational philosophies, really. They're about involving everyone in the organization in ongoing efforts to improve processes and meet or, ideally, exceed expectations.
And it's a lot like that Kaizen idea from Toyota.
Very similar spirit, yes. Continuous incremental improvement driven from all levels.
And these TQM, CQI approaches, do they have common characteristics?
They generally do. Things like linking quality efforts directly to the organization's main strategy, having a dedicated quality council, often with top leadership involved.
Makes sense. Leadership buy-in.
Absolutely crucial. Also, training programs for staff, clear ways for people to suggest improvements, setting up teams to work on specific process problems, supporting those teams, and having policies that really encourage participation.
And a key thing I remember reading is avoiding blame, right? Focusing on the process, not the person.
Yes. That's fundamental. If people are afraid of being blamed for errors, they won't speak up about problems or suggest improvements. It stifles that continuous improvement culture.
Which leads to ideas like just culture or a culture of safety.
Exactly. Especially important in healthcare, where you have different professionals, techs, physicians working together. You need an environment where it's safe to report issues so the system can learn.
But applying all this in healthcare must have its own unique wrinkles compared to building cars.
Oh, absolutely. Huge differences. For one, think about who the customer is. Is it the patient having the test? The doctor who ordered it? The insurance company paying for it?
Yeah. They might all have slightly different ideas about what quality means.
Right. And there's often not great transparency about costs versus benefits. There's a big knowledge gap between patients and providers. Plus, human biology isn't standardized like car parts.
Good point. Lots of variability.
And then there's the huge issue of data privacy, protecting patient health information, handling peer-reviewed data sensitively. You can't just share everything openly like you might in a factory setting.
So how do they gather quality data then?
That's where bodies like quality improvement organizations, QIOs, and patient safety organizations, PSOs, come in. They provide ways to collect and analyze quality and safety information in a compliant, often confidential way.
Okay, so navigating all that complexity.
Yeah.
How does a lab actually do the improvement? You mentioned a cycle earlier.
Yes, the PDCA cycle. Plan, do, check, act. Sometimes called the Shewhart cycle. It's really foundational.
Walk me through it quickly.
Okay. Plan. Identify what you want to improve and plan a change or test. Do. Carry out the plan, implement the change on a small scale. Check. Observe the results, analyze the data, see what happened, did it work, act. Based on what you learned in check, you either adopt the change, adjust it, or abandon it and start the cycle again with a new plan. It's iterative.
Plan, do, check, act. Keep cycling through.
Exactly. And in healthcare, you often see a related model called OSHI-PDCA.
Focus say PDCA.
Adding another layer. Sort of. Focus is like a detailed front end to the PDCA cycle, helping teams get started. It stands for find a process to improve, organize a team, clarify the current process, understand the sources of variation or problems, and select the specific improvement strategy.
FOCUS. Find, organize, clarify, understand, select.
Okay, that sets you up nicely for the plan stage of PDCA.
Precisely. It gives structure to that initial phase.
All right, we've covered the systems, the philosophy, but what about the actual measurements in the lab? Getting the numbers right on that ultrasound. That's where these quantitative imaging biomarkers fit in.
It is. So a biomarker, Bradley, is just something measurable that indicates a biological state, normal process disease, response to
Run
treatment.
blood sugar for diabetes.
Exactly. And imaging technologies, ultrasound, CT, MRI, they give us pictures, but they also generate data. When we pull out specific objective measurements from those images that relate to anatomy or function, those are quantitative imaging biomarkers, QIBs.
So turning pictures into precise numbers, that's the idea. Things like the degree of stenosis in an artery or flow velocity.
Okay, and if we're talking measurements, there must be some key terminology to know if those measurements are actually any good, reliable.
Absolutely. Got another language. First, there's the measurement. That's simply the specific thing you're trying to measure.
Like the diameter of the carotid artery.
Perfect example. Then there's the reference value, a generally accepted value you compare against, and precision, which is all about consistency. How close are repeated measurements to each other?
Okay, precision, is that just one thing?
Well, it has two key aspects. Repeatability is precision under the exact same conditions, same operator, same machine, same patient, short time interval.
Okay.
Reproducibility is precision under varied conditions. Different operators, different machines, maybe different days.
So repeatability is doing the same thing over and over. Reproducibility is whether different people or machines get the same answer.
You got it. Then there's bias. That refers to systematic error, how far off the average measurement is from the actual true value.
And true value, is that achievable in medicine?
Well, that's the tricky part. The true value is often theoretical. All measurements have some inherent error or uncertainty. We talk about truth or true values, but we have to acknowledge it's an ideal.
Right, which leads to the idea of a gold standard.
Exactly. A gold standard is a test or method that we assume represents the truth that has no error for the purpose of comparison. But, crucially, even gold standards can have limitations or errors themselves.
So it's the best available reference, but maybe not perfect.
Often, yes. Now, accuracy combines both bias and precision. It's about how close a single measurement is likely to be to that true or gold standard value.
So you want low bias and high precision to be accurate.
Ideally, yes. Assessing accuracy usually involves comparing your test to that gold standard. But like we said, finding a perfect gold standard in vascular testing can be tough. Sometimes the ultrasound is the best test we have.
So what do you do then?
In those cases, you might focus more on assessing precision, especially reproducibility. For instance, having different technologists scan the same patient, blinded to each other's results.
Okay. Now, assuming there was a gold standard, maybe angiography or surgery, how do we describe how well the ultrasound agrees with it?
Right. That's where we get into terms like sensitivity and specificity.
Classic metric.
When the patient actually has the disease according to the gold standard. How well does it pick up the disease?
Okay. High sensitivity, few false negatives.
Correct. Specificity is the probability that your test is negative when the patient does not have the disease. How well does it rule out the disease in healthy people?
High specificity, few false positives.
Exactly. Then you have positive predictive value, PPV, and negative predictive value, NTV.
Right. These depend on how common the disease is, don't they?
They absolutely do. PPV is the probability that a person with a positive test result actually has the disease. NTV is the probability that a person with a negative result truly doesn't have it.
So a test could have great sensitivity and specificity, but if the disease is really rare, a positive result might still have a high chance of being a false positive. Lower PPV.
Precisely. The pretest probability or prevalence of the disease in the population you're testing heavily influences PPV and NPV. It's really important context.
But judging a test isn't just about these calculations, is it? There's more to quality.
Oh, definitely. These metrics tell you about agreement with a standard, but the clinical utility is broader. How effective is the test in actually helping doctors make good decisions for patients?
Right. Does it change management?
Yeah,
Improve outcomes?
exactly. And because test use can vary a lot, professional societies develop appropriate use criteria, or AUCs, to guide clinicians on when a test is genuinely indicated and helpful.
That makes sense. Ensuring the test is ordered for the right reasons in the first place.
And you also have to consider patient and provider perceptions. Surveys might gauge satisfaction, perceived usefulness, and efficiency. Does the test reduce the need for more tests, maybe more invasive ones? Does it avoid costly delays or repeats?
So multiple dimensions to test quality beyond just the raw accuracy numbers. Okay, we've covered the drive for quality, the systems, the measurements. Let's finally get to accreditation. What's the core purpose here for a vascular lab?
Accreditation is basically an external validation process. It provides assurance to patients, doctors, payers that the lab meets recognized standards of quality and competence.
So it's like a stamp of approval. What kind of things do they actually look at?
They typically review a whole range of things: staff qualifications and training, obviously, how the lab handles its quality assurance for data and records. Documentation practices, are the methods they're using scientifically valid? Is the equipment properly calibrated and maintained? It's pretty comprehensive.
Okay. And why would a lab go through all this? It sounds like potentially a lot of effort.
Good question. There are usually three main drivers. One, regulatory requirements. Sometimes accreditation is needed to get paid by Medicare or other insurers.
The compliance angle.
Yep. Two, competitive advantage. Being accredited signals a commitment to quality, which can attract patients and referring physicians.
Marketing, almost.
In a way. And three, impartial guidance. The process itself can provide valuable objective feedback to help the lab improve its own processes, efficiency, and ultimately patient care.
So it can be a real driver for internal improvement too, not just an external check mark.
Ideally, yes.
But you mentioned effort. Is it resource intensive?
It definitely can be. Setting up and maintaining robust quality management systems takes time and resources. This can be particularly challenging for smaller, independent labs compared to big hospital systems.
So that's where these third-party accreditation programs really help. They provide the structure.
Exactly. They offer a framework, tools, standards, and guidance that a lab can use to build and demonstrate its quality system, perhaps more efficiently than starting from scratch.
And who are the main players doing this accrediting for imaging?
Well, CMS, the Centers for Medicare and Medicaid Services, has approved several bodies for diagnostic imaging. There's the American College of Radiology, ACR, the Joint Commission, RADSite, and the Intersocietal Accreditation Commission, or IAC.
Yep.
And then some professional organizations like the American Institute for Ultrasound in Medicine, AIUM, or the American College of Cardiology, ACC, also have accreditation programs often focused on specific areas.
And you mentioned the IAC specifically in relation to vascular labs earlier.
Right. The IAC has a division specifically for vascular testing, IACVT. It actually grew out of an earlier organization, the ICAVL, which was founded with strong backing from vascular surgeons specifically to improve vascular ultrasound quality.
So they have deep roots in this particular field.
They do, and they've maintained this approach of involving multiple medical specialties, which makes sense for vascular disease.
So what's the actual accreditation process like for a lab applying to, say, IACVT?
It generally involves the accrediting body setting clear standards first. Standards for the facility, equipment, policies, staff qualifications, safety reporting, QA, everything.
Based on guidelines and best practices, presumably.
Yes, often drawing heavily on professional society guidelines. Then, the lab has to demonstrate compliance. This usually involves submitting detailed documentation, data, and often undergoing an on-site visit or survey.
Okay. Any unique aspects to the IACVT process?
Yeah, one key thing is their requirement for labs to submit actual complete diagnostic case studies, images, worksheets, final reports for peer review by experts.
So they're not just looking at policies on paper, they're looking at the actual work product.
Exactly. The reviewers assess things like, was the indication for the exam appropriate? What was the technical quality of the imaging? Was the interpretation accurate and consistent? Was the report clear and timely? It's quite a thorough review of the core diagnostic function.
That sounds rigorous. So for accreditation to be really effective, what does it need?
Well, the standards themselves need to strike a balance. They should be based on solid evidence, be reasonable and achievable for different kinds of labs, big hospitals, small clinics. They need to evolve as medicine and technology change.
Right. Keep up to date.
And crucially, the process shouldn't be perceived as overly burdensome, excessively costly, or driven by self-interest of the accrediting body. Ideally, it should feel like a collaborative partnership between the lab and the accreditor, focused on improvement.
And maybe technology can help with that collaboration. Image sharing, online submissions.
Absolutely. There's definitely potential there to make the process more efficient and maybe even more effective.
Okay. Accreditation sounds valuable, but maybe not perfect.
Hmm.
Are there acknowledged shortcomings or criticisms of the current models?
Yes, there are definitely areas for discussion and potential improvement. A big one that labs often mention is the administrative burden.
The paperwork.
Exactly. Gathering all the required documentation, case studies, data for the initial application, and then again for reaccreditation, which is typically every, say, 2 or 3 years. It takes significant staff time and effort.
And that could potentially pull focus away from the day-to-day quality work.
That's the concern. You might get this cycle where everyone gears up for the accreditation survey or submission, and then maybe things relax a bit until the next cycle rather than maintaining constant vigilance.
The accreditation cycle effect.
Yeah. And because it's periodic, it might not capture shorter-term changes that affect quality, maybe staffing changes, new equipment, protocol updates, leadership shifts.
But things can change quickly in a lab.
They can. Another point is that, as we noted, many imaging accreditation programs don't require submission of actual case studies for review, unlike IACVT.
And even with IACVT, you said it's usually a small sample.
Right. It might be just a handful of cases, and there's always the possibility that a lab submits its best work, which might not fully represent typical daily performance.
Okay. What about internal reviews? Don't labs do their own QA?
They do, and accreditation often requires or recommends regular internal QA meetings, often involving peer review. But sometimes there isn't super specific guidance on how to conduct these reviews most effectively to really drive improvement.
So the intent is good, but the execution might vary.
It can. Traditionally, a lot of vascular lab QA involve correlation studies comparing ultrasound results to findings from angiography or surgery.
Checking against the gold standard, essentially.
Yes, and that's definitely valuable for education and identifying major discrepancies. But it might divert attention from optimizing the daily processes within the lab itself from the moment the test is ordered to the final report going out.
Focusing on the outliers rather than the whole system.
Potentially, yes. And while continuously evaluating every single study internally would be ideal from a pure CQI perspective, the time and resources needed are just prohibitive for most labs.
Makes sense. So, given all this, is there strong evidence that accreditation definitely works, that it improves quality?
That's a bit controversial. While it's widely adopted and intuitively seems beneficial, there's actually a surprising lack of extensive, high-quality published literature, definitively proving that accreditation consistently leads to measurable improvement in actual quality outcomes for non-invasive cardiovascular imaging.
Really? That's interesting. So it's more assumed than proven.
Well, I wouldn't get quite that far.
Yeah.
The standards themselves are generally evidence-based or based on expert consensus. The process enforces a certain level of structure and attention to quality. Most people believe it helps. But rigorous, large-scale studies demonstrating a direct causal link to better patient outcomes, specifically from accreditation, are somewhat scarce in this field.
Okay. So with these limitations and questions in mind, what's the future look like? Are accreditation models evolving?
They definitely are. There's a clear trend towards incorporating more continuous quality improvement principles and leveraging technology, moving away from just the periodic snapshot.
Like the changes you mentioned with IECVT.
Exactly. Their updated standards from 2020 are a great example. They've shifted the emphasis somewhat away from just those traditional correlation case reviews towards requiring more frequent, structured internal evaluation of the lab's entire workflow.
The whole process, from request to report.
Yes. Labs now need to regularly self-assess their performance in 4 key areas.
Which are?
Appropriate use. Was the test needed? Imaging quality. Were the pictures good? Interpretive quality. Was the diagnosis accurate? And report completeness and timeliness.
Okay, a much broader internal look.
Right, and to help with this, the IAC developed an online QA application. It provides specific metrics chosen from those used by their own expert reviewers for the lab to track internally.
So tools to support this ongoing self-assessment.
Exactly. And the vision is that the IAC could potentially review these ongoing self-evaluations, maybe provide benchmarking data so labs can see how they compare to peers, and offer more continuous feedback and guidance between the formal accreditation cycles.
That sounds much more like a partnership for continuous improvement.
That's the goal. And there's also the idea that maybe this kind of online, ongoing review of selected cases or metrics could eventually supplement or even replace the need to submit huge batches of full case studies for reaccreditation.
Which would reduce that administrative burden we talked about.
Potentially, yes, while still giving the accreditor a more realistic, longitudinal view of the lab's performance.
So it's moving towards being more integrated into the lab's daily work.
That seems to be the direction. But it's important to note those traditional clinical correlation reviews haven't gone away entirely under the new IAC standards. They're still considered a valuable part of QA meetings and continuing education.
Still useful for learning.
Absolutely. They help reinforce understanding and foster that culture of Kaizen, of everyone technologists, physicians feeling ownership of the lab's quality.
This has been incredibly insightful, really peeling back the layers on quality assurance and accreditation in these vascular labs. So to kind of wrap it up, it sounds like ensuring high-quality diagnostic testing is, well, it's complicated but absolutely essential. It borrows heavily from manufacturing principles, adapting them to the unique world of healthcare. Accreditation provides a really valuable structure, a baseline.
Definitely gives a framework.
But ultimately, true continuous quality improvement needs that active, ongoing engagement from every single person working in the lab. It's a cultural thing, isn't it?
It really is. It has to be embedded in the daily work.
So here's a final thought for you, the listener.
As these accreditation models evolve towards more continuous internal review, and as technology plays a bigger role, how might your own expectations of diagnostic imaging change? If you're a patient or a referring doctor, what questions maybe should you be asking about a facility's real commitment to ongoing quality?
That's a great point. It encourages a deeper look beyond just the certificate on the wall. We definitely encourage anyone interested to check out the websites of the accrediting bodies like the IAC or ACR and look at the kind of standards we've been discussing today. There's a lot more detail out there.